3. Antithrombotic therapy after acute coronary syndrome or PCI in atrial fibrillation. Definition. Antithrombotic therapy is the fundamental treatment to prevent thrombotic complications and death of several cardiovascular disorders such as ischemic heart disease, atrial fibrillation, and stroke. Double inhibition of platelet aggregation by combining acetylsalicylic acid and P2Y12, while oral anticoagulation with a vitamin K antagonist or with the new oral anticoagulation has the maximum efficacy in atrial fibrillation.
Triple antithrombotic therapy is the standard of care for patients with atrial fibrillation undergoing percutaneous coronary intervention, or PCI, with stenting. Oral anticoagulation and dual antiplatelet therapy with a P2Y12 inhibitor plus aspirin are used to prevent thromboembolic events, including stroke, systemic emboli, and stent thromboses, but they are associated with a high risk of major bleeding. A potential therapeutic strategy to reduce thromboembolic events and bleeding risk is dual therapy, with the oral direct thrombin inhibitor dabigatran and a P2Y12 inhibitor without aspirin. In the multicenter randomized redual PCI trial, 2,725 patients with non-valvular atrial fibrillation who had undergone PCI with stent implantation within the previous 120 hours were randomized to receive either triple therapy with warfarin, a P2Y12 inhibitor, either clopidogrel or ticagrelor, and aspirin for 1 to 3 months, or dual therapy with dabigatran, 110 or 150 milligrams twice daily, and a P2Y12 inhibitor.
Application in nursing. Nursing plays an important role in the early restoration of the obstructed artery release. Pain and of the sometimes provides all the comfort necessary so that the patient comfortable and set.
So you've probably seen this before. If you have atherosclerosis, so if you didn't listen carefully to Dr. Pownell's lecture earlier, and you've done things to lower your HDL, you've intentionally raised your HDL, and you like to smoke, and you eat too much, this is what you get. You need to see that. So effective classes of antiplatelet therapy. There are 4 that you need to know about. Aspirin, cyclooxygenase 1 inhibitor, probably to a small extent a cyclooxygenase, well, never mind. Think of it as a cyclooxygenase 1 inhibitor. Largely this blocks amplification of the platelet activation sequence. ADP and the P2Y12 receptor antagonists. Who knows what P2Y12 is? Okay, great. When we're done, you will. Who knows what the ADP receptor is on platelets? Raise your hand. Okay, great. Because there is no the ADP receptor. There are 3 different ADP receptors on the platelets, and they're each targets of different therapeutics that are being developed. These largely block activation and subsequent aggregation of platelets. Primarily, they are not anti-aggregants, although that's one of the downstream effects. GP2B3A antagonists block aggregation. They do not change. They may... Now, Bashar, write it down. I don't want to see 325 in the order sense. Thanks.
Pros and cons. Pros. It indicates to prevent strong and systemic embolism in patients, preventing thromboembolism events. Cons. It is associated with a risk of intracranial hemorrhage.
Right, good afternoon. I'm Michelle Corbin for Fits on the Go from the Mayo Clinic in Rochester, Minnesota. Today we have with us Dr. Renato Lopez. He just presented the late drinking trial at the American College of Cardiology conference 2019. We are really happy to have you with us, Dr. Renato Lopez.
Thank you very much for the invitation. A pleasure to participate. Everything that is fellows related, I'm really pleased to participate and help.
Thank you. So let's start first by talking about the Augustus trial that you presented this morning. So why don't you tell us a little bit about the design of the trial and the results of this trial?
So the Augustus trial basically is a trial that we try to answer two questions. Because in this field of antithrombotic therapy for patients with ACS and AFib or PCI, it's a challenging group of patients. Because the patients have to use anticoagulant for the AFib, they need to use a dual antiplatelet for the ACS or PCI, and when you combine those therapies, it becomes a challenge. And there have been some other studies trying to minimize risk of bleeding with some strategies. But we felt that we wanted to answer two questions. We needed to answer two questions. So first is we wanted to test apixaban versus VKA, vitamin K antagonists. And second, the role of aspirin, because aspirin is such an important piece now that we wanted to have a head-to-head comparison on aspirin versus placebo. But to answer these two questions in a single trial, the only way to do it is if you do a 2x2 factorial design study. So that's what we did. So the trial basically enrolled patients with AFib with an indication for oral anticoagulation and also who had a recent ACS or a PCI where there was a need for a P2Y12 inhibitor for at least 6 months. And then we randomized patients to apixaban, 5 milligrams twice daily, which is a dose approved for stroke prevention in atrial fibrillation, or VKA with a target INR between 2 and 3.
Used apply in Ecuador. The coronary syndrome is the set cause of death in the Ecuador. The estimate of prevalence of coronary disease in the population is difficult.
Antithrombotic therapy for more than half a century, and I've watched the evolution of anticoagulant therapy from the old standard of heparin and warfarin, and I think that the first major breakthrough was the introduction of low molecular weight heparin in the 1980s. This truly changed the way that we manage patients with thrombosis, both acute treatment and also prevention of thrombosis. Subsequently, we developed drugs that target single coagulation factors, and the prototype of that was fondaparinux. I had the pleasure of being involved in the early work with both of these agents, both low molecular heparin and fondaparinux, and they still remain one of the principal ways of treating patients acutely by parenteral administration of anticoagulants. There was a very important development in antithrombotic therapy. It was based on a much better understanding of coagulation, and it was possible to target single coagulation factors. The two main targets are factor 10 and thrombin, both key in the coagulation cascade, and it was possible to synthesize drugs that target both factor 10 and thrombin to inhibit coagulation. Factor 10 is a key coagulation factor, and it's not a surprise that much of the development was targeting activated factor 10, and there are now 4 factor 10 drugs available worldwide: rivaroxaban, apixaban, edoxaban, and butrixaban. The thrombin inhibitor, dabigatran, is also available. This is an effective agent, but the development of thrombin inhibitors was set back by a drug called zimalagatran, an effective anticoagulant thrombin inhibitor, but was associated with hepatic toxicity. And there's a concern that this might be a class effect of thrombin inhibition. As it turns out, that's not the case. and the dabigatran is effective and does not have that problem. But I had the pleasure of being involved with the early development of these drugs clinically and did some of the first dose-finding studies and subsequently the phase 3 trials, particularly with rivaroxaban, demonstrating its effectiveness both in prevention of thrombosis, treatment of thrombosis, and a reduction of stroke and atrial fibrillation. These drugs, in my view, will completely revolutionize the management of patients who require long-term anticoagulation. They're orally active, they do not require anticoagulant monitoring.
Conclusion. Triple therapy with DREL, combined antiplatelet therapy and oral anticoagulation may be indication in the certain clinical situation for a short time to prevent serious thrombolytic events.
This session is called What's Next Upcoming and Ongoing Clinical Trials. And the idea is that we would like to keep you awake after the lunch break. And Professor Lewis calls this the clinical trial parade. So what we will do is show you slide after slide, trial after trial in a rapid fire. So lots of information, but there is no time for question and answer. So this is not meant to be that we discuss the trials. It's more that you see what's cooking. So you can lean back and just listen. Don't fall asleep. And there's more coming, of course, today. So there's a lot more for you. Okay, so our study cohort is published, and this drug is available in Europe, as you may know. It's Praxbind and andexanet alpha. It's the ANEXA trial. Interim results were shown, and approval is pending. There are several issues that need to be solved, so we still have to wait for this drug. Okay, my last thing is 11 inhibitor. So what is the rationale? Factor 11 is implicated in clot formation, but not in hemostasis. So the idea is if we inhibit this, we will have less thrombosis, but not as much bleeding. This is the rationale behind this. And this has been investigated with an antisense oligonucleotide. And in VTE patients, this worked. So the nucleotide produced less VTE events and less bleeding. So this was a small first trial. And now there's an antibody that is developed, and this antibody will be tested in a clinical trial called the Foxtrot study, where different dosages will be compared with enoxaparin and apixaban. So this is something very new and upcoming, very interesting principle. And I will finish this. So important, I think it's CAD, it's ACS. I don't know if you know this very important study from Finland, okay, from Mr. Kivimäki, published in The Lancet. This is investigating the working hours per week and the risk of coronary artery disease and stroke. And you know, cardiologists think we all die from heart attack because we have to work so much. And I can show you here it's not true. The risk of heart attack is not higher. But look at this, check it out. If you work more than 55 hours a week, you have a high risk of stroke. So you got to be careful. There you go. So now we may have an explanation for this. Look at this. If you work more than 55 hours, you have a higher risk of atrial fibrillation. So there you go. But be careful. This is just an association. It's not a causal relationship, okay? In terms of science is just an association. And I have something else that you have to keep in mind, and then I'm done, Basel, and then it's your turn, which is very interesting. Working hours and risk of divorce. To tell you, the ladies in the room, there's no association whatsoever for the ladies, but for the men in this room, which is very interesting. There's a dose dependency showing the longer the working hours of the men, the lower the risk of divorce. Okay, yes. So now you have to think about what you want. You want stroke or being divorced? Think about this, and with this, I'm done. Thank you very much. There are no questions allowed, and Basel Lewis will continue with his talk.
Thank you very much.